Hi, everybody. Welcome to Pediatric Grand Rounds. Thanks so much for being here. And now I have the pleasure of introducing Dr. Lori Ruttman, who's a pediatric emergency medicine attending physician at Seattle Children's and a professor with the Department of Pediatrics at the University of Washington School of Medicine. She also leads the QI Scholars Program here. She's the medical director of the Sepsis Oversight Program and directs scholarship for the Center of Quality and Patient Safety, among many other things. So excited to have her here today. Welcome, Dr. Ruttman. Thank you so much.
Thanks for the introduction, Suzanne, and thank you for the invitation to be here and the opportunity to present. As Suzanne mentioned, I'm Lori Ruttman. I'm a physician in the emergency department here at Seattle Children's and direct our sepsis oversight program. I am particularly excited to be presenting on sepsis today because for those who don't know, September is Sepsis Awareness Month, and this is part of our kind of Sepsis Awareness Month campaign to have a grand rounds as well. So I have no financial disclosures or conflicts of interest. So the objectives for the next 45 minutes or so are to first critically assess the current literature describing disparities in pediatric sepsis recognition, care delivery, and outcomes. We'll then review the role of quality improvement in pediatric health equity, and finally discuss potential approaches to designing interventions that promote equity in sepsis care. Before we dive into sepsis, I'd like to take a step back and frame our discussion about health disparities in medicine in general. Healthcare disparities are real, and they are not new. 40 years ago, in 1985, a landmark report marked the first convening of a group of health experts by the US government to conduct a comprehensive study of racial and ethnic minority health and really elevated minority health issues to the national stage. In the early 2000s, we saw publications from the Institute of Medicine and AHRQ outlining profound disparities in the health and healthcare delivery of ethnic and racial minorities. On the next couple of slides, I'll introduce two deeply intertwined forces that drive healthcare disparities: social determinants of health and racism. Social determinants of health are the conditions and the environments where people are born, live, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. These 5 categories are the social determinants of health. Health and healthcare access are a part of the equation, but economic stability, education, neighborhood, and social and community context are also vitally important. In fact, as we can see on the right here, healthcare only contributes a fraction of what produces health. An individual has an accumulation of life experiences that contribute to their health outcomes. I'd also like to share a framework for understanding racism as a contributor to child health. A recent review of racial and ethnic inequities in pediatric care in the United States, published in The Lancet, presented this ecological model of racism to display the various drivers of care inequities. I like this model because it includes both the structural factors, the social determinants of health from the last slide, and interpersonal factors, such as implicit bias, which we'll get to later in the talk. So with that high-level background to frame our discussion, let's dive into the literature on disparities in pediatric sepsis and eventually to how we can improve care for all children. As many of you are aware, sepsis is the body's life-threatening response to an infection. It affects 1.7 million people and takes approximately over 350,000 adult and pediatric lives every year in the United States alone. Severe sepsis remains a leading cause of mortality among pediatric patients worldwide. This is truly a global health problem. Today, we're focusing only on studies from the United States. Since the 2001 inception of the Surviving Sepsis campaign, a substantial decline has been noted in sepsis-related mortality among US children. But despite these advances, racial and ethnic disparities persist. Disparities exist in adult and pediatric sepsis incidence, mortality, hospitalizations, and care delivery. We'll review the literature in each of these areas. The factors contributing to disparities in pediatric sepsis are complex and multifaceted, ranging from differential recognition, approaches to treatment, access to healthcare services, provider bias, and patient awareness and education. When considering what underlies disparate outcomes, it's critical to remember the broad social determinants of health framework from a few slides back, especially if we ultimately want to develop interventions to promote equity. So let's dig in. Studies from the adult sepsis literature over the past 2 decades describe troubling disparities in sepsis incidence and mortality by race and ethnicity. They found that Black and other non-white individuals have nearly twice the incidence of sepsis and a higher incidence of severe sepsis as whites. Blacks bear nearly twice the burden of sepsis deaths relative to the size of the Black population as compared to whites. And sepsis deaths among American Indians and Alaska Natives and Hispanics are also elevated compared to whites. It's not just adults. So this study looked at severe sepsis by age and race. They categorized race in the study as Black, white, or Hispanic in 6 US states. In this figure, you see that sepsis incidence is on the y-axis and age is on the x-axis. We're pediatricians, so your attention is likely diverted to the lower end of the age axis, where I have a red circle. What we see there is a higher sepsis rate among Black newborns compared to white and Hispanic children. Importantly, this disparity in incidence of sepsis persists into adulthood. As we reviewed, the adult studies suggest not only disparities in the incidence of sepsis, but in mortality from sepsis across racial and ethnic groups. Let's take a closer look at pediatric sepsis mortality described in the literature in the past few years. This large study included over 100,000 episodes of severe sepsis from 2003 to 2014 in the Kids Inpatient Database. In their multivariate analysis of both patients with severe sepsis and septic shock, Black and Hispanic patients had a higher odds of mortality than Caucasian patients. This large population-based retrospective cohort study also used data from the Kids Inpatient Database. Their study included over 12,000 children with severe sepsis admitted to over 1,200 hospitals in the US. With regard to sepsis mortality, they found that Black race was associated with a higher mortality compared to white and Hispanic race, and also that Black and Hispanic children had longer hospital stays than white children. This retrospective cohort used 4 years of data from the Kids Inpatient Database and found the risk of in-hospital mortality among children with sepsis differed by patient race, geographic region, and insurance status. Compared with white children, the adjusted risk of mortality from sepsis in this study was 9% higher for Hispanic children, 17% higher among Asian and Pacific Islander children, and 27% higher among children of other racial minority groups. And finally, this study by Lee and colleagues was a retrospective analysis of the 2009 to 2018 national inpatient sample. They included over 475,000 pediatric patients with sepsis diagnosis codes. With regard to mortality, they found a significant disparity in risk-adjusted mortality rates between Black and white patients that persisted throughout the decade, whereas Asian, Hispanic, and white patients had comparable mortality. Let's move beyond incidence and mortality to the care that children experience when they're in the hospital. This single-center study from the Children's Hospital of Philadelphia found that non-Hispanic Black patients treated outside of an electronic screening alert were less likely than non-Hispanic white patients to be identified and treated for sepsis. There's actually more interesting context to discuss about this study, so we'll put an asterisk here and come back to this one a bit later. In this recent population-based retrospective cohort study of the 2019 Kids Inpatient Database, independent variables were race, ethnicity, and payer. Outcomes were the Agency for Healthcare Research and Quality Pediatric Quality Indicators, or PDIs, and the analysis included over 5 million children. For context, PDIs focus on potentially preventable complications and iatrogenic events for pediatric patients who are treated in hospitals. Researchers here found that compared with white patients, Black and Hispanic patients had significantly greater odds of 5 of the 7 safety indicators, and the largest disparities occurred in postoperative sepsis. And compared with privately insured patients, Medicaid-covered patients had significantly greater odds in 4 of the 7 safety indicators, again with the largest disparity in postoperative sepsis. It's important to state here that even when they adjusted for private versus public insurance, the disparities by race and ethnicity persisted. These findings are alarming, but unfortunately not new. This older retrospective study analyzed the National Surgical Quality Improvement Program pediatric database from 2012 to 2017. The investigators reported that compared to their white peers, Black children had almost 3.5 times the odds of dying within 30 days after surgery, nearly 20% greater odds of developing postoperative complications, and 30% greater odds of sepsis. I found this figure particularly telling from this study. It depicts the incidence of postoperative mortality and complications according to race among the 140,000 apparently healthy children in the study. White patients are represented by the lined bars and Black patients with the solid bars. Post-operative complications are listed on the vertical axis. As you can see, sepsis is just one small part of the post-operative disparities that this group describes. The authors of the study conclude that the disparities in post-operative outcomes may not be fully explained by variation in preoperative comorbidities. Clearly, the breadth and depth of disparities in incidence, mortality, and outcomes that we've reviewed thus far are not fully explained by racial variation in comorbidities or underlying individual patient differences. I'll remind you of these figures from the start of the hour. The contributing factors to healthcare disparities are multifaceted and complex and driven by social determinants of health and multiple levels of discrimination and racism. To highlight the contribution of social determinants, we'll review a few studies here that illustrate the impacts of economic instability and health and healthcare access on sepsis disparities. This study of neonatal sepsis mortality found that infants and children with lower levels of income and access to insurance are at greater risk of sepsis mortality. Specifically, infants from lower income families were 20% more likely to die from sepsis. Further, infants from families without health insurance are 3 times more likely to die from sepsis. Drilling down on resource, use, and outcomes, this study found that children with severe sepsis or septic shock with public insurance are more likely to die than children with private or other types of insurance. Access to intensive care and hospitals with lower mortality rates is related to income and minority status. This study showed that healthcare resources, including the availability of ICU beds, are more plentiful in wealthier communities. In the US, nearly half of the lowest income communities have no ICU beds, whereas only 3% of the highest income communities have no ICU beds. Other studies showed that sepsis patients of any race and ethnicity who are treated in predominantly minority-serving hospitals have higher rates of in-hospital mortality. I'll ask you to kind of hold the thought on the impact of neighborhood for a little bit later in the talk. Finally, as we consider the impacts of social and community context and education on sepsis disparities, I'd like to share a few results from the annual Sepsis Awareness Survey conducted by the Sepsis Alliance. The survey was conducted online among approximately 2,500 adults living in the United States. The results were weighted to the US Census for age, gender, race, ethnicity, region, and income. Importantly, surveys were conducted in English. The survey found that those who identify as Black or Hispanic are significantly less likely to have heard the term sepsis than those who identify as white. Further, those with less education and lower household income are less aware of the term sepsis. And this racial disparity in sepsis awareness exists even for those participants at the same education level. Finally, the Sepsis Alliance survey found that among respondents who had heard the term sepsis, those who were white were more likely to identify all 4 symptoms of sepsis from a list of options over respondents who identified as Black or Hispanic. Okay, so that concludes our review of the literature, and it's a lot. You might be feeling overwhelmed at this point, like the woman in the cartoon, and I do want to mention that, again, that I limited the studies that I presented to those just in the United States. We would need longer than this hour to really discuss and dig into the global disparities in pediatric sepsis care. So where do we go from here? What I'd like us to think about today are the ways in which we can apply QI principles to address disparities and improve equity in the care delivery for sepsis. This is not a new idea. This report from the Joint Commission from nearly 15 years ago urged us to leverage quality improvement to improve equity in healthcare. Since that report, there have been several papers promoting the partnership between quality improvement and health equity approaches. I would like to focus for a few minutes on this article by our very own Dr. Casey Lyon. A central argument in this paper is that all QI interventions are health equity interventions because every care process change has the potential to improve, maintain, or worsen an underlying disparity. That is, there are 3 possible outcomes for QI interventions on equity. We'll review each of them. The first thing I'd like to point out is that this run chart is stratified so that the baseline disparity is identified. We'll look at more examples of this in a moment. QI interventions can lead to improvement, more in the advantaged population, which would widen that disparity gap. Improvement for all, but maintenance of the equity gap, which is equality and improvement. Or what we hope will happen, That is that the improvement is more in the disadvantaged population, thereby decreasing that baseline disparity gap. This figure shows the ideal outcome for an equity-focused QI project. As you see, stratifying the groups shows the baseline disparity and improvements over time for all, with narrowing of the gap between the groups. Keep this kind of image in mind, and we'll shift gears a bit to discuss a few examples of ways to operationalize QI tools to promote equity. The first step is really to examine, identify, and understand the existing disparities. Understanding the pre-existing disparities allows us to consider system-level factors in intervention designs, and remembering that QI interventions are most effective for populations that they were designed for, by, and with. This paper describes some of the work in our own emergency department here at Seattle Children's to use data visualization and a QI framework to reduce disparities in care. I recognize there's a lot of text here, and you're not expected at all to read through the details. The reference is on the slide if you'd like to read the full manuscript. But the point here is, through this multidimensional project, we sought to incorporate equity as central to the provision of safe, high-quality care. The goal was to truly identify and understand existing disparities in our emergency care, display them on a dashboard, and focus our QI interventions to promote equity. Before we move on, I wanted to briefly mention the Emergency Severity Index, or ESI, because you're going to see this several times on the next few slides, and I recognize that not everybody in the audience works in emergency medicine. ESI is a triage acuity score that is widely used in emergency departments. Essentially, ESI numbers are assigned to a patient when they arrive in the emergency room, and a lower ESI number indicates higher acuity conditions. As you can imagine, the ESI level that's assigned determines how quickly a patient is evaluated, the timeliness of their care delivery, their length of stay, et cetera. It certainly puts a label on the urgency that that patient needs to be evaluated. It's a driver of much of the care that follows when a patient is in the emergency room and subsequently even throughout their hospital stay. So back to our dashboard. In addition to visualizing our quality data, we were interested in stimulating discussion about the origins of the disparities we may see. Here's one example from a page of the dashboard where it shows a map of our city on the left with historical red line districts from the 1930s and 1940s, and on the right are present-day average triage levels. First, I'll direct your attention to the red and yellow neighborhoods on the left, which were historically considered hazardous during redlining. And now look at the corresponding neighborhoods on the right. The lighter and darker gray colors represent lower triage acuity levels, and the pink and red colors represent higher triage acuity levels. So you can visually get a sense of how historical structural racism is related to the differences that we are seeing today in our emergency department. To build our dashboard, we turn to the quality data that we track in our own ED and stratified it by race, ethnicity, and language for care. As was mentioned, it's critical to examine, identify, and understand existing disparities in order to focus areas for QI interventions. We started with baseline data from fiscal year 2020. Here you can see some of the data compared by language preference. The gray represents English-speaking patients, and the green are patients with a language for care other than English. On the top left, we show the average ESI acuity score, and then the area under the curve for ESI on the right. On the bottom, you can see the wait time for attending sign-up, the overall length of stay, 72-hour return rates. These are all meant to visually display where we may see inequities in our care. These are the same data, now shown by patient-reported race and ethnicity. At the top, you can see our overall ED demographics. And each bar then represents a different category of race ethnicity for that mean ESI acuity level. ESI area under the curve, attending sign-up, length of stay, and return rates are all also displayed here. We also highlighted differences in average triage scores across a range of common diagnoses. Fever is a common presenting complaint for patients at risk for sepsis. And here you can see the difference in average triage scores between patients with fever who are non-Hispanic white on the left and black on the right. As a reminder, lower numbers here means that you're going to get seen faster and have care delivered sooner. I'm highlighting the fever diagnosis here because it relates to sepsis, but hopefully you can see from this display that non-Hispanic white patients in our ED were assigned more acute triage scores than black patients across all of our most common diagnoses. The trends in triage disparities I shared from Seattle have unfortunately been documented in numerous other pediatric institutions. But why? One contributor to the sustained disparity may be the subjective nature of several components of the ESI. As you can see here in this conceptual algorithm, the first three considerations, is the patient dying? Is this a patient who shouldn't wait? And how many resources might this patient need, are based entirely on subjective clinical judgment, with vital signs really the only objective component of the score. When screening or assessments are subjective and left to clinician judgment alone, individual biases can perpetuate disparities. Reminding you again of this image from earlier in the talk, as this is where we're going to dive into the impact of interpersonal interactions and the concept of implicit bias. Implicit or subconscious bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases, which encompass both favorable and unfavorable assessments, are activated involuntarily and without any awareness or intentional control. Implicit bias has been well studied and measured. The Implicit Association Test, or IAT, is a computerized, timed, dual categorization test that measures implicit preferences by bypassing conscious processing. The IAT is part of Project Implicit, which is a collaborative investigation between Harvard, UVA, and the University of Washington. The studies examine the thoughts and feelings that exist either outside of the conscious awareness or conscious control. And the goal of the project is really to make this technique available for education, including self-education and awareness. Between October 1998 and October 2006, more than 4.5 million IAT tests were completed on the IAT website. The project found that implicit bias is pervasive. People are often unaware of their implicit biases. Implicit biases predict behavior, and people differ in levels of implicit bias. I've added the website here for those who'd like to take a test or better understand your own implicit biases. And as a healthcare provider, taking the IAT is probably worth your time. Implicit bias has been well studied in healthcare providers and occurs at the same or higher levels as in the general population. So if our implicit biases are contributing to and perpetuating these disparities, how do we mitigate bias? One approach, common in QI interventions, is to use technology to build checklists and decision algorithms. This study that I referenced earlier demonstrated the power of leveraging technology in automated sepsis screening over bias-prone clinician judgment. Again, this was the single-center study from CHOP with electronic sepsis screening in place. Patients could be identified as at risk for sepsis, either through a fully automated screening process in Epic or by clinician judgment. The authors found no disparity in patients who were identified by the automated alert, but non-Hispanic white patients were more likely than non-Hispanic Black patients to be identified and treated if they were in the clinician-identified group. Care standardization is the next QI tool with potential to powerfully impact disparities in sepsis. The concept of reducing variation through standardization is surely familiar to you all. We have a very extensive clinical standard work department here at Seattle Children's, and until care is standardized, it's very difficult to move to the desired target improvement. So the final example that I'd like to share today, especially as it relates to the concept of care standardization, is from a study that I recently published in BMJ Quality and Safety in collaboration with the Children's Hospital Association's Improving Pediatric Sepsis Outcomes, or IPSO Collaborative. In 2016, the IPSO Collaborative was established to standardize and improve pediatric sepsis care across over 50 hospitals in the United States. There were actually 66 hospitals at peak enrollment. Since that time, numerous studies have been published about this large QI collaborative's impact and outcomes. But little was known about the collaborative's impact on equity. So we sought to assess the association between the Child Opportunity Index and pediatric sepsis care delivery and outcomes, and determine if baseline disparities in care change over time among hospitals in the IPSO, or Improving Pediatric Sepsis Outcomes Collaborative. A little more about the Child Opportunity Index, since I haven't really talked about this yet. I'm sure many of you are familiar with this index. But if not, the COI is a multidimensional measure of neighborhood-level conditions needed for healthy child development. It includes 29 neighborhood and census tract indicators that impact children's healthy development across 3 domains. Education, health and development, and social and economic are the 3 main domains. The indicators are weighted, aggregated, and transformed into z-scores, and then each is categorized into very low, low, moderate, high, and very high child opportunity levels. In version 2 of the COI, neighborhood and census tract information has been aggregated to the zip code level as well, and so we applied COI categories at the zip code level for this Ipsos study. Okay, so back to the study. We conducted a retrospective analysis of Ipsos sepsis episodes from 2017 to 2021 linked to patient encounters in the Pediatric Health Information System database. The primary exposure was COI. The reason that we linked these two databases is that they are both managed by the Children's Hospital Association, and as part of the Sepsis Quality Improvement Collaborative, we weren't routinely collecting race ethnicity data or zip code data at the individual patient level, but we were able to cross-match the patients who were in the IPSO QI database with patients in FIS to get at some of that geocoded data. We estimated differences in the proportion of patients in each COI quintile identified via a standardized sepsis recognition protocol, and for IPSO that was defined as the use of a screening tool, having a sepsis huddle documented after sepsis was recognized in a patient, and or the use of a sepsis order set, and who received a bundle of recommended care. So the bundle of recommended care included having sepsis recognized, plus an IV fluid bolus within an hour, and IV antibiotics in less than 3 hours. Over 30,000 Ipsos sepsis episodes were included in the study from 24 participating hospitals. As I mentioned on the slide prior, sepsis recognition was defined as the use of a screening tool, a sepsis huddle, or an order set, and it's represented here on the y-axis. The year of the study is on the x-axis, and we separated children who presented to the pediatric emergency department from those in all other care settings, and this included patients on the general medicine floors, in the hem-onc units, and in the ICUs. As you can see in these charts, sepsis recognition in the pediatric emergency group started at a much higher level, around 70%, compared to 30 to 40% for all other care settings. This is almost certainly because pediatric emergency departments in this study, many of them participated in earlier sepsis QI work, including the Pediatric Septic Shock Collaborative, which was hosted by the AAP several years before the IPSO Collaborative even formed. So there was a lot of work already to standardize sepsis care in pediatric emergency departments in the US, less so on inpatient units. So let's focus on the care settings who had the greatest opportunity for improvement in sepsis recognition, those outside of the emergency department. The lines on this chart represent the 5 Child Opportunity Index quintiles. As you can see, recognition improved for all groups over the 5 years of the Sepsis Collaborative. When the work started in 2017, the greatest disparity was seen between those in the very low and very high COI quintile. Over time, with participation in this large QI collaborative focused on standardizing sepsis care, the greatest improvement in sepsis recognition occurred for children in the lowest COI quintile, essentially closing that baseline gap. So why did it work? There are a few hypotheses that we considered when we looked at the results of our paper. The first was really standardized care processes. So this IPSO collaborative promoted evidence-based clinical pathways, the use of standardized order sets, and automated sepsis screening tools built into the EHR whenever possible to reduce reliance on individual clinician judgment and thereby hopefully minimize bias. Next, participating sites engaged in really structured quality improvement education, data feedback, and that allowed lower performing hospitals to adopt effective practices from peers and accelerate improvement. And finally, we did a sub-analysis in this paper. I'm not presenting the results here, looking at hospitals with the largest proportion of low COI patients. And those hospitals, there were 4 that kind of stood out as having a very high proportion of low COI patients, had actually the lowest initial performance, and also showed the greatest improvement over time, suggesting that the collaborative really helped support and close gaps in care for patients who were being seen in hospitals or from populations with a very low kind of initial child opportunity, that the effect of the collaborative and sharing the resources really mitigated some of those neighborhood impacts. So all of this supported our conclusion that intensive quality improvement collaboratives can improve sepsis care for patients, and particularly for those who are the most socially disadvantaged. And health systems should measure outcomes in vulnerable populations and engage in structured quality improvement to help mitigate disparities. So in summary, that brings me to the end of my talk. To summarize, disparities in pediatric sepsis incidence, mortality, hospitalizations, and care delivery exist. And there is a wealth of literature to support this. Again, today we really only looked at the literature from the United States, but there's a huge body of well-designed studies to support this sepsis disparities. They're perpetuated by factors at the system level, like social determinants of health, and at the individual level, like the issues of racism and implicit bias that we talked about. And quality improvement can, and maybe should, be utilized to help mitigate disparities. The first step, as we looked at in some of the earlier slides, is really stratifying baseline data and understanding where disparities exist, so stratifying data by race, ethnicity, language. And then finally, tools such as process automation, care standardization, really show promise as interventions to promote equity in sepsis care. I do want to put in a plug for a Grand Rounds next month, where there will be a talk on global pediatric sepsis. So again, I did not address that today, but Teresa Kortz is coming from UCSF to discuss that next month. I'm going to end there with plenty of time for questions, so thank you for your attention.
Hi, Laurie. Thanks for this. This is really great. I really liked how you highlighted how we can use QI to improve equity. As an inpatient person, it's really interesting also to think about how like the ED does, is higher already. I mean, this is somewhat of a rare event when you think about like each individual provider, even though like across the hospitals it's obviously not a rare event. How do we address that, and how do we, we want to identify these kids without doing like way too much for all these other kids? So sort of how do we thread that needle?
Yeah, thanks, Mercine. That's a great question. It is a rare event on inpatient units. And I will say, just for like added context, in our IPSO data, 70%, 2/3 of the patients in the entire data set had their sepsis event in the emergency department. So of all kids in this collaborative that, went through multiple sites at many, many hospitals, the majority of kids with sepsis do present to the ED, and it is a much less common event when it happens on inpatient. So by the numbers, it's just less common, which makes it harder to identify. And once kids are admitted, they usually already have another diagnosis. They may have abnormal vitals all the time, right? It's harder to see those changes. So it is a very, very sort of tough issue to address. One thing that we're doing here now, so as in my role as kind of the sepsis oversight program director, we're working to revise our inpatient both pathway and order sets. For those who have ever tried using our inpatient sepsis order set in like the past 5 years, it's like terrible. I didn't actually even realize, as an ED provider, I didn't realize how bad or cumbersome it was until we started looking at it to make improvements. So we're hoping that by incorporating automated screening, which I think now exists both for clinical deterioration and for sepsis risk into EPIC, and continuing to sort of interrogate how accurate that screening is and trying to make it better so that providers are alerted to think about sepsis. And then 2, making it easy to sort of do the right thing and order the right things once there's concern for sepsis through hopefully better order sets and more streamlined pathways, which are all supposed to go live on September 30th. Closing out Sepsis Awareness Month. They all should go live on September 30th, but I hope that will help. I think like the key is just to think to yourself, and we've tried building this into some of our risk nurse protocols, like to think to yourself, like, could this be sepsis? Because kids present in so many different ways. Like maybe it's not respiratory distress, maybe it's not abdominal pain, maybe it's not just a headache, but it could be sepsis. And sort of having it front of mind is probably the other way to try to not miss those cases. Great question.
Other questions? I see hands moving.
back to the ED, I was curious if you've seen any differences in the last couple of years when we've like totally changed how we triage patients with ORCA, and if you've looked into that now that there's like more often a provider that sees the patient first.
Yeah, that's a really great question. Thanks for that. So actually, I'll put in like a double plug here for the QI Scholars Program, because one of our QI scholars this year is a nurse practitioner in our emergency department working with our ED microsystem who's been looking at exactly that question. So we changed our model of care in the emergency department in the past couple of years to put a provider in triage and to have kind of a team approach to when patients come into the ED to get them seen faster, and to also have kind of more of a like multiple eyes on a patient, which helps, I think, drive potentially more accurate triage because there's just multiple opinions. People are talking about the patient and looking a little bit more kind of critically at them when they first arrive, hopefully mitigating some of the bias and hopefully changing some of those outcomes. So her project is still underway, but we are looking at exactly that, whether that change in a model of care and change in the triage process can change some of those disparities in ESI acuity scoring.
Thank you for this tour de frappe. I wonder what happens to the majority of the United States patients who live in rural areas, not in places which you perform the studies. Out there, I think we are still in the last century. And how can we improve the care of the majority of patients who do not have access to well-established centers, which you have used as basis for your studies?
Yeah, I think that's a really great question, asking about kind of rural sites and patients who are in, you know, not major children's hospitals, major academic centers. Collaboratives like the CHA Collaborative did include some community sites that were not necessarily big academic pediatric centers. So I do think there's some promise there if community sites can get into larger kind of collaborative efforts where they're kind of benefiting from working with other hospitals, because without a lot of resource and investment, building out some of these structures that really like automate care, you know, get the care delivered quickly, it's a huge investment. I mean, and it's a lot for, I think, a community hospital to try to do that. So I think collaboratives are one way that can happen. And then I think, you know, we do a lot of work in peds emergency medicine to try to bring simulation to rural sites, try to bring some of the best practices into, you know, more community settings where most kids are getting their care. But it's a challenging problem, and I think you're right that the geographic differential is probably one that is even more profound, where if you're in a rural site, if you don't have all the access to all the resources, it will drive those disparities.
Any other hands that I missed? Just a comment from online from Dr. Walker. Thank you so much, Lori, for not just highlighting disparities due to bias and providers' judgment, but to showing there are solutions that can improve and optimize care for every child needing sepsis care. Great work. Thank you so much. If there are no other questions, I'll give everyone the rest of their Thursday morning back, and let's give Dr. Ruttman a big hand. Thank you so much for being here. This is really, really good. And thanks for celebrating Sepsis Month with us. We'll see you all next week. Thank you.